Welcome to Good Medicine, a podcast about the ideas, people, and conversations shaping the future of healthcare. I'm your host, Dr. Rohan Ramakrishna, neurosurgeon and co-founder of Roon. Each episode will explore how medicine is evolving through honest conversations with leaders and change makers. Good Medicine is brought to you by Roon, the digital home for doctors. We're a free, physicians-only community to connect, share knowledge, and shape the future of medicine. I recently sat down with Dr. Chelsea Clinton, Vice Chair of the Clinton Foundation and Clinton Health Access Initiative, to talk about what's happening in healthcare in America right now, particularly with respect to reproductive care and medical research. A few things from our conversation really stuck with me. First, there's a lot of deliberate confusion being injected into our healthcare system. Providers are constantly being forced to second guess whether they can deliver even basic care, not because of medical reasons, but because of shifting legal interpretations and political interference. Second, even though reproductive rights win overwhelmingly when people vote on this issue, even in conservative states, we're still struggling to help most men understand this as their issue too. And third, the ongoing attacks on scientific research aren't just about budget cuts. They're actively driving talented people out of the field and undermining our future, a future of scientific discovery and of better health outcomes. Chelsea brought a data-driven, equity-focused perspective to all of this, and I think you'll find it really compelling. Let's dive in. Chelsea, thank you so much for joining me on Good Medicine.
Oh gosh, well, Rohan, thank you so much for that generous introduction, and I'm particularly looking forward to talking about maternal health in this country and around the world, because as you said, we are certainly not doing everything that we know we could do and should do to try to ensure that women here in New York City, where we both live and work, or around the world, are healthy and safe throughout their pregnancies and afterwards.
So I first want to get into sort of how you came into this work, starting from when you were a kid. And so I think you and I are roughly the same age, I think. And during your most formative years, you had this inside look at state level politics, national politics. So I'm curious, during that young period of your life, what were some of the lessons that you absorbed around the dinner table in Arkansas and in Washington that have really guide you today?
Well, certainly around the dinner table and the breakfast table, particularly the breakfast table, where one of the first things I learned how to read was the newspaper. And so I would read the Arkansas Democrat or the Arkansas Gazette. They're now one paper, but when I was a little girl, they were two separate papers. And I would read stories about sometimes work that my parents were doing that they were advocating for. My dad kind of as a governor, and my mom as a legal aid lawyer or as an advocate for women and kids, whether for expanded maternal health benefits or for higher kind of public education standards in Arkansas. And sometimes things that, were really pertinent to me, like what was on the school lunch menu for the upcoming week or school calendar. Were the teachers going to go on strike? And we would then talk about these kind of issues of the day, how they affected me and my parents. One of the kind of critical lessons I think they taught me was the difference between fact and opinion, and to be, very firm that even when I was kind of articulating my opinion and arguing for my point of view, that I was marshaling kind of facts to support that. I think one of the other real kind of gifts that they gave me was that they always valued my opinion, right? It wasn't just like this perfunctory, like check a box, ask Chelsea what she thinks. Or like, well, what do you think about kind of this question? What do you think the right answer is? And I think that gave me the gift of high expectations, candidly, of being well-informed, of having, well thought out opinions. Of course, what they expected out of me when I was 7 was, I think, radically different than when I was, say, 17. And that they then shared also what they were working on. And I also spent a lot of time, candidly, I'm an only child, like trundling around the state of Arkansas when I was a kid. And so sometimes that was to things like the International Duck Calling Contest in Stuttgart, Arkansas, which was amazing. And to like hear people like call different types of ducks, sometimes with duck collars, sometimes with their hands, and trying like 18 different types of duck gumbo was like such a fun thing to do every year. But also sometimes like going to town halls where people would be talking to my dad about what they thought agrarian financing should be or what they thought should happen in their local county hospital. So I learned so much, yes, around like the dinner table and the breakfast table, but also just like being out in Arkansas and then later, around the country with my parents.
I'm curious, either in Arkansas or Washington, were there any memorable conversations with people that you think in retrospect help push or guide you towards a career in public and maternal health?
Well, I have a clear memory of when I first got really interested in public health. And admittedly, it came from watching the nightly news back when that was just kind of what most people did. And my dad was running for president. It was 1991. I was in his Little Rock campaign headquarters and I was stuffing envelopes because when you're 11 years old and your parent is running for office, you can basically call people and try to tell them why you hope they're going to vote for your parent or persuade them to vote for your parent. You can hand out stickers or maybe American flags or campaign signs, or you can stuff and stamp envelopes. And I certainly have done all of those things for both of my parents over the years. At this instance, I was stuffing envelopes and the nightly news came on and the broadcaster was talking about the courageous decision that Magic Johnson had made to come forward with his HIV status. And there was a relatively long piece, a few minutes, which a 30-minute kind of nightly newscast is a substantial kind of devotion of time. And I was so curious, and I remember this, it felt like an intellectual and also like an emotional reaction. I was curious why the broadcaster had framed this story initially in courage. Like why was there something about Magic Johnson Health that like required him to be brave? So I got really interested, although I couldn't have articulated it in these words or using this vernacular at the time in stigma and also in HIV and AIDS and in kind of what we were doing to try to help people know their status, what was treatment, what was prevention, and kind of asking all those questions very much then kind of are the through lines to the work that I'm privileged to be part of every day across the Clinton Foundation and the Clinton Health Access Initiative.
So, after Washington, you headed off to college and you went to Stanford and you studied history, if I'm correct, right? And I think
history and human biology.
Okay, and your senior thesis was on the Good Friday Accords, is that correct? Mm-hmm. And so I ask about that because, that was a landmark peace accord that was painstaking multi-party negotiation. And I'm curious, as you think about where we are today, were there lessons from that thesis that you think, are well applicable to today's environment?
Oh, goodness. Well, Rohan, I don't think I've read that thesis in many years, but certainly kind of casting my brain back to that time and, having been able to interview so many of the people who were involved in kind of different stages of that, and also going back and reading kind of the long history of attempts to kind of forge, make, or force peace in Northern Ireland. Certainly, the adage that you don't make peace with your friends kind of reverberated kind of throughout while I was kind of doing my kind of research and then writing. And also the fierce focus on the future, which was something that I found quite profound and is something that I think about often these days, that if we are going to move forward in a contentious space, kind of valuing the future more, what could be possible if we were to agree on a common set of kind of standards, norms, kind of behaviors, acknowledge what trade-offs kind of were in everyone's least worst interest or best interest, I think is a very different mindset than the kind of articulation and the enumeration and the primary platforming of kind of past grievances, as valid as kind of they all might be. And one of the things I've always learned from my parents, which kind of goes back to one of your earlier questions, is the belief that tomorrow really can be better, and that it's not just something that is like printed on a Hallmark card, but this deep sense of kind of the moral choice of optimism in action, and the willingness to find ground if it's there, even with people whom you might otherwise vehemently disagree with on certain areas. And I think it is more kind of that zeitgeist and that ethos, I would say, that I learned a lot from my parents, and also absolutely people who worked for years or sometimes even decades on the Good Friday Accords.
Yeah. Shifting to the crux of today's interview, you seem, at the Clinton Foundation and the Health Access Initiative to have a broad portfolio. You've done amazing things with Too Small to Fail as an example. But I'm curious, you seem to have a particular passion, if I may, if at least from my perspective, on maternal health, reproductive health, reproductive access, or access to reproductive care. So I'm curious, where did that start, and what invigorates you to pursue that work?
Oh, goodness, Rohan, I don't know. Unlike kind of my interest in public health, that I really can pinpoint to a quite kind of specific point in time, and even kind of envision myself back in that place and kind of watching that news broadcast. Um, I've always kind of been interested in and felt a responsibility to families, and I think that that's partly because of how I grew up and watching the work that my parents did, and being deeply mindful of how both blessed and kind of privileged I've been. Blessed to have healthy parents who I never doubted loved me and supported me and championed me, to have had amazing grandmothers who I lost too soon and yet were in my life in very meaningful ways, to have wonderful friends, to have a safe place to grow up, to have enough food to eat, to have like wonderful ways to stretch my mind and my body as a kid. So many gifts that I am mindful that I have in my life, and kind of very much the credo of to whom much is given, much is expected, kind of was a through line in my childhood, particularly driven by my grandmothers. And I say that because I think even as a kid, I was mindful of like, well, what more can I be doing to try to help support, champion, kind of ensure there is a different and better future, whether for other kids or when I was little, like for people older than me. And now I think I feel that so keenly, as a parent, and also mindful of how much worse maternal health has gotten in this country over the course of our lifetime, since we're around the same age. That I would be 50% more likely to die in childbirth than my mother is just such a kind of chilling reality, and one that I think should be unacceptable, regardless of whether you're a parent or not, or whether you're a woman or not, or whether or not you think you care about healthcare or health equity. It should matter to all of us, because it's such a strong signal for how we have kind of failed at what I think is a fundamental kind of promise of the social contract, which is that we take care of the next generation. We take care of those who kind of bring the next generation into the world. And so I think it is just this kind of deep instinctive sense, but built on, a lifetime of wondering about, how to make our communities healthier, how to help better protect kids, how to help kind of better support families, that kind of led to that kind of visceral sense of recognizing like how unjust this is, particularly because we know that the vast majority of maternal deaths are preventable. And yet we don't make the policy or the programmatic choices and investments that we know we should make to help prevent women from dying while pregnant or in childbirth or postpartum.
Yeah. So switching to sort of current events, I'm curious, there's this new EMTALA rule that the Trump administration handed down, or this new interpretation or lack of enforcement. Can you talk to us about what that means or is, and sort of the implications?
Well, I think, EMTALA is the rule of the land. I mean, it is the law. So despite the Trump administration rescinding, the Biden era guidance that really was largely just an affirmation that federal law protects emergency room doctors and other emergency room providers to be able to provide the necessary urgent care that anyone would need who walks in through the door. But in this instance, that pregnant women who are in need of abortion care for whatever kind of reason of medical distress that they might have walked in or been rolled into, rushed into those kind of emergency rooms, that providers are protected, legally protected, and actually legally required to provide that care. And so that that law is inclusive of hospitals and also of the doctors and the nurses and the other providers who work kind of within hospitals or clinic settings. And so I think everyone who understands that, particularly the lawyers who understand that, need to hopefully be on podcasts like yours and kind of speaking kind of in any way in which they could with kind of megaphones, large and small, to reassure hospitals, doctors, nurses, that the law of the land hasn't changed, and that not only are they still able to kind of provide the care that they know patients need, but they are mandated by law to provide that care in emergency rooms. And whatever the Trump administration may say, it doesn't change kind of what the original EMTALA, the Emergency Medical Treatment and Labor Act, has maintained for many, many, many years.
I hear you what you're saying in terms of what the law of the land is, but clearly there's some confusion around what this new lack of narrowing EMTALA's definition of stabilizing treatment. But so I'm curious, how do you think this is going to play out on the ground for OBGYNs that have to take care of these patients in emergency rooms with restrictive access?
Rohan, I think, this administration is very good at confusion. I mean, that's the word you use. They're very good at kind of the constant injection of different rules or executive orders or interpretations, different alternative quote unquote facts to bring back a term of art from the first Trump administration. And kind of in that confusion, is done with real, I certainly believe, kind of clarity and also harmful intent to create kind of the chaos of needing to constantly absorb the information that's coming, sort out what is true and is not true, orient yourself, whether you're an organization, an institution, or like an individual, into like, what do you need to care most about when so much is being kind of launched into kind of the effective barrage every day. And so I certainly have enormous sympathy for anyone who's trying to kind of navigate through that, whether you're a researcher and you get a stopgap order one day and then it may be rescinded, or maybe it's partially rescinded but partially not, or maybe you can only do this part of your research program but not that. Now maybe your university is asking you to have kind of cost savings, but maybe now there's going to be some additional supplemental funding. I mean, it's confusing for everyone. I think particularly, Rohan, for people like you who are at our academic medical institutions and absolutely our frontline care providers. I believe, and the lawyers and the policy people that I've spoken to, are very clear that the Trump administration's recent kind of clarification or recent recension of the Biden era additional guidance doesn't change the underlying law of the land, and that there have been many cases that have tested that over time, and that the courts have, broadly speaking, consistently ruled that EMTALA is inclusive of care, of just care, including reproductive health care, that patients who come into emergency rooms desperately seeking it, that they deserve to receive that care, and that providers should be able to operate knowing that they are protected in providing that care.
Yeah. Outside of EMTALA, though, clearly access to reproductive care has been under assault, for the last several years in ways that I think probably all took for granted for a long time. And I'm curious, what stories have you heard or studies have you read recently that show the impact of these restrictive statutes on women who are trying to get care?
Oh, Rohan, I mean, so many. I mean, more than we have certainly time for today. And my mom and I produced a documentary that came out last year called Zarowski v. Texas that followed Amanda Zarowski, who is the named lead plaintiff in a suit suing Texas for their confusion in the medical exceptions to their very strict abortion law, because she and the other plaintiffs in the suit did not receive timely medically indicated abortion care. In Amanda's instance, she was multiple days into sepsis before doctors felt like she was at the brink of death, and they finally were legally protected under the kind of Texas law to intervene and save her life. Her experience, though, compromised her fertility. Like, how could anyone claim that that was a pro-life stance in practice? Or the women that we know have died, particularly in Texas and Georgia, because the doctors waited too long. These were women who were in healthcare facilities or who had recently seen healthcare providers and were told that they needed to wait until they were sick enough, such that the providers felt like they could have a legal protection, a kind of legally kind of enforceable mandate to intervene and just to practice medicine and just to deliver healthcare. And unlike in Amanda's case, they waited too long and the women died. We also now know from Texas and Georgia that data around maternal health and mortality is either no longer being collected or no longer being shared, unclear. And so it will be harder to have public scrutiny because that is the intention of kind of either no longer asking for the data at the state level or obscuring public access to the state level data so that inquiries are stymied, so that we are not able to see how many women are being harmed and possibly losing their lives because of these deeply draconian, unscientific, non-medical based, ideologically driven laws that are, despite what the lawmakers tell you, with exceptions to save a mother's life, are not adequately saving mothers' lives. And we now have, like, painfully, a death toll that attests to that.
Yeah. How do we, and there's probably no answer to this question either that's satisfactory, but how do we support these frontline providers, whether they're OBs, et cetera, that have to navigate this legal limbo, in their everyday practices? Is there anything we can do to help?
Well, Rohan, thankfully there are lots of people, in these states certainly who are, providing just the solidarity of community. I've heard from providers how much it means to them when they, yes, hear from patients, but also when they just hear from the people that otherwise they might see in the grocery checkout line or at church or at a soccer match or a baseball game, that their fellow community members know that it's really hard, that they are being put into impossible situations every day when either they're expected to betray their Hippocratic oath, to act as if they don't know what the right answer is, or to possibly jeopardize their medical license and face, at least in Texas, up to 99 years in prison, which, particularly if you're a parent or a partner, you own your own practice, you have other people who depend on you, first and foremost your children and your spouses, but also your employees in some instances. And so I think I've heard from providers how much it means to them when they hear something, and this may sound very old-fashioned, but I think particularly when so often we relate to each other through screens, as wonderful as they can be, like that's how you and I are talking today, when they kind of hear from people in person, either kind of through letters or kind of through people coming up to them. I think also there are legal funds that anyone who's listening, if you have the resources, if this is a way that you want to be supportive and to contribute to, some that exist at a kind of federal level, like the Center for Reproductive Rights is doing a lot to challenge these laws and also prepare to kind of stand and defend providers. They are going to be charged under these laws, whether they're in Idaho or Iowa, Georgia, Texas, Arkansas, or elsewhere. And then there are also many state level efforts to help provide kind of legal resources to providers, and also something that I think is really important, a lot of state level efforts to help support providers who want to testify in front of state legislatures or state medical boards, to really help the people who have the power to make different decisions, to introduce different pieces of legislation, or to, from a state medical board perspective, kind of provide greater clarity around kind of what exceptions should be, must be, kind of given all that we now have learned about how inert and ineffective they are in actually protecting women, protecting patients, and protecting providers' lives. So I think there are many different ways to be supportive of providers. And I certainly don't want anyone to think that there aren't like really important, vital efforts to provide that support happening at state levels, because there very much are.
I'm curious, when reproductive access has been on the ballot, it's done very well. And I'm curious, as you reflect on the last election, why do you think is there, I mean, obviously it's very complicated, but I'm curious your view as to why it didn't really put that message over the top. Like, why was that not enough? Was that fighting just a cultural thing in broader strokes related to the Trump administration? Like, what do you think was the reason it didn't rise to the top of the voter mindset?
Well, I think that I respectfully say Rohan isn't giving voters enough credit, because certainly, again, in states where voters could vote, overwhelmingly, voters voted to protect reproductive health access when that was the question on hand, or to restore reproductive health access when that was the question on hand. And not only, in quote unquote blue states like New York, but even in very red states like Missouri or Florida, where we got more than 57% of the vote. But the way that the constitutional amendment process has recently been rendered, we required 60% of voters to vote to affirm a woman's kind of right to reproductive health care in Florida. So we didn't get to the 60% threshold, but 57% is still well north of 50%. And so I think, certainly wrong what we saw in the last election, but also what we saw in elections previously, where voters had the chance to vote again in some very red states like Montana. Voters overwhelmingly voted to protect or restore a woman's right to choose. And so to me, that certainly says that the 2024 kind of general election, if you're asking about the race between Vice President Harris and President Trump, was not about reproductive health. It was about many other things, or maybe it was about reproductive health and many other things. But I don't think it's accurate to say that reproductive health wasn't top of mind for many voters, because quite a few voters said they actually went to the polls to be able to vote on the referendum or the constitutional amendments that were on kind of their state ballots, as well as vote for president. But they really came to vote, whether they were voting for or against, to ensure that their voices were heard and their votes were counted on that issue.
Yeah. I guess that question comes from a place of surprise, given that these issues affect everyone in the population. There's broad, whether you like it or not, it affects everybody, right? And so
I think that we're on and we've done a lot of work with a terrific man named Warren Jacobson and Men for Choice. So I certainly want to give him and his organization and others doing similar work credit for trying to help men understand that reproductive health access isn't just about women. I mean, if I think about all the women that I've met, that we worked with through the process of making Zurowski v. Texas, and certainly that I've, had the honor of speaking to since, when they were denied health care, when they were worried about dying, like that certainly affected their husbands and their partners. It affected their fathers and their brothers. If they were already mothers of sons, it certainly affected their boys. And so I think you understand that, and I understand that. And there are many people who are trying to help more of us understand that. I still think that there is a big delta between kind of what we know to be true, and certainly, what so many of the women I've spoken to and their husbands have spoken to, would say to be true. I don't think yet, though, that most men, whether they're fathers or not, yet feel like this is their issue too. I also know that we are making progress. If we look at survey data, more men did feel like this was relevant to them, in the last election cycle than in previous election cycles. And so that says to me that all of these collective efforts are making a difference, and also that we have more work to do.
Yeah. I want to move on to sort of public health research, scientific research, and sort of the squeeze or delays and sort of funding that we're seeing. And I'm curious, what are the actual impacts? Like, educate our listeners, like on funding delays, et cetera, for Title X, PEPFAR, et cetera, that you're seeing in maternal health, global health, et cetera.
Well, Rohan, we have certainly the research that already has been halted, either because of research that's at particular institutions that have been targeted, by the Trump administration, Harvard and Columbia most notably, but not singularly. We have the stop work orders that have reverberated across not only funding from the NIH or the CDC, from health research, but also from the Department of Energy and the Department of Agriculture, the Department of Defense, and certainly that has had a real, larger chilling effect than just kind of the research itself that has been halted. And we also, know, Rohan, that it's not as if we can just like flip a switch. Like even if all the funding came back, the months of research loss that we've already incurred, will have effects for years to come. I mean, the work that was stopped on studying like the different ways in which Alzheimer's expresses in women versus men, it will be very hard to kind of restart that work, and certainly will take years to get it kind of back to kind of where it was when the funding was halted, is just one example. And we know that it's not only the research funding directly that will have an impact. We live here in New York City. I often really very much subscribe to it's like the greatest place on earth, and I'm so happy I live here. And also I'm so grateful and proud of having grown up in Arkansas. We think about the proposed cuts to Medicaid and Medicare, but Medicaid specifically, that's going to have a catastrophic impact on rural hospitals. There are a lot of rural hospitals that are also doing really important research, whether in partnership with larger academic medical centers or not. And so it's not only kind of the big headline numbers of, the Trump administration is proposing to cut NIH funding by 40%, and the tens of billions of dollars that equates to, money then that won't be going into kind of frontier cancer research, that won't be going into neurology, that won't be going into HIV/AIDS, it won't be going into cardio metabolic health, but it's also kind of all the other enabling supportive architecture that also was fundamental to our research ecosystem and enterprise as a country that will be weakened if kind of the current budget, as it's being deliberated, whether from the House or what the White House proposed, is passed. And it's not then only about kind of what we're squandering to not discover to help make us healthier or more sustainable, and all of the companies that could be created out of that, and the jobs that could be created out of that, and of course the medicines and the therapies, and yes, also the vaccines that could be created out of that. I think the threat of brain drain is very real. I mean, we have whole new offices that are being supported by the French government, by the Dutch government, by the European Parliament. I have friends, and I'm sure you do too, who are being recruited, whether to Singapore or Saudi Arabia or Italy or Canada or any of the other places I've mentioned. I think, the survey that Nature did, which now is almost 2 months old, where, it said, that there were hundreds of top funded researchers who were, thinking about leaving the United States. 2 months later, I'm sure that number has gone up. So it's both the funding freezes and then retrenchments that concern me, and for all then that we will not discover or innovate on or catalyze to be built in this country. But it's also that we are kind of purposefully denuding ourselves of the researchers and the scientists and the innovators, yes, who that funding enabled, but even those who still may be funded may not want to work in this climate, may not want to build in this climate, may not want to innovate in this climate. And so I'm concerned across the board when I think about any of that. And then when I think about what all of that can mean for our future, it certainly seems to me that we are actively depreciating our future and undermining what historically I would argue has helped make America great.
Yeah. That beyond the brain drain itself, that what you articulated, that fatigue that everyone that's staying behind has to endure in this particular climate is a real thing.
And I think, the really brave NIH scientists who published, a letter recently criticizing the administration's cuts in public health research also made it clear that for all of the kind of narrative around free speech and now being able to speak your mind, that is not the way that they feel within the NIH, that they are not able to actually be heard when trying to reach kind of leadership either at the NIH or the HHS level to help the Trump administration appointees understand the real value of their work and the real value of how they've done their work and the real academic rigor and intellectual integrity kind of behind how kind of grants are assessed and then ultimately funded. So, and I really worry about all of this being catastrophic broadly, but particularly harmful to women and women's health research. Because we know that women's health research has already been disproportionately frozen through the various kind of stop work orders. We know that the Trump administration is looking to get rid of multiple offices, some of which have existed, for generations, that are specifically oriented to understanding kind of women's health, women's lives, whether it's the Bureau of Labor Statistics, kind of Office of Women in the Labor Force, or the more recent Women's Health Initiative constituted under the Biden administration. So things that have literally existed for more than 100 years or even a few years, but all of which clearly had very clear purpose and logic to help us understand kind of the health and well-being of women kind of broadly or while working, or to help us better understand and to research women's health, which has historically always been underfunded and under-resourced and under-researched, to then better have a landscape of kind of what we should further invest in the future. We're squandering all of that.
Yeah, couldn't agree more. I know you have to leave in a few minutes, so I want to get to the end, which is sort of our quick hit section. So if you had to wave a magic policy wand in order to improve maternal mortality in the United States, what would you do?
I would, one, I certainly would, restore with stronger protections, kind of full reproductive health access and choice in this country, because we know there's a very clear correlation between kind of non-evidence-based policies that restrict a woman's right to choose and a provider's ability to provide care, and rising rates of maternal mortality and morbidity. So if I could, I guess, choose one wand, I would choose that one. But if I kind of had a few others, I would certainly ensure that every pregnant woman has kind of presumptive eligibility for Medicaid, which is currently not true, so that anyone who's pregnant doesn't have to worry about insurance coverage. I think we don't do a good enough job, actually, of helping women understand the importance of prenatal visits, women both on Medicaid and commercial insurance or who are self-insured. I think we need to really do a better job of that. And we need to make it easier for women who often do understand what they should be doing to be healthy in their pregnancies to make those healthy choices, right? All the things that we also know to be true, right? To have better access to clean air, whether they live, in a place where that's readily available or not, like the Houston shipping channel, right? Access to healthy food, ability to walk more, mandated maternity care that's paid leave, right? We're ignominiously one of fewer than 10 countries for where that's not true. So I think there's a lot, again, that we know that works to help protect pregnant women, some of which we talk about a lot these days, like ensuring women have the right to choose and doctors have the ability to provide care, and some of which I don't think we talk enough about, like actually ensuring that women who are thinking about pregnant or who may be newly pregnant understand the importance of going to see our providers, midwives, doctors, during the course of our pregnancy.
Yeah, thank you for that. Favorite mentor or most impactful mentor?
My most impactful mentor is probably Dr. Paul Farmer.
Amazing guy, from everything I read about him. Book recommendation?
Oh my gosh. So the more stressed out I get, Rohan, about the world, the more I just read mysteries for fun. Because I consume so much news every day, both like news articles and also, whatever is coming out in all the public health journals or the medical journals. And so I consume a lot of content for work and to feel like I can be a good citizen. And so I read a lot of mysteries when I get really worried about the world, because there's a beginning, middle, and end. Right? The bad guys are caught. Like there's accountability generally. Hopefully there's also justice. And so I'm deep into this mystery series written by a man named David Housewright that is set in St. Paul, Minnesota. And it's great. I'm on like number 8, I think. I also love reading long mystery series. Probably my favorite mystery series of all time. It was written by this woman, Barbara Nadal. They're set in Istanbul about a detective, Inspector Eichmann. So I love reading mysteries because they provide me an escape from the moment and a deep sense of like resolution, and like the bad guys can be defeated and good can prevail, and there can be real accountability and real justice, even if sometimes it takes longer than any of us would hope.
I similarly have gotten into podcast mysteries, and there was one about that combined Motley Crue and Noriega and drug trafficking in Florida. It was fascinating.
I mean, that sounds amazing. I love 80s hair band music, and I'm a proud kid of the 80s, so also we'll try to find that.
Yeah. And then last question, if someone did a documentary about you, what would the intro music be?
The intro music be. Oh my gosh. This is so hard to answer right now, Rohan, because all 3 of my children are obsessed with music in a wonderful way. Like they all play instruments, they all sing. My youngest son wants to be a rock star. And everything we listen to now is really led by them, and they have very eclectic taste that I have to get back and try to find like that space as a parent where I can both appreciate all their tastes and remember or rediscover or newly find like what my taste is. Because right now, like my 5-year-old who wants to be a rock star is obsessed with Beethoven and Bob Marley. And my 8-year-old is very into just basically like groups. He's really interested in it. Sort of, he's agnostic to what era, but he's like fascinated by like rock bands, I would say, of every era. And then my daughter, probably like most 10-year-old girls in America, think like the most important people in America are Taylor Swift and Beyonce. And so I'm like, right now, I think the intro music would need to be a mashup of all of that. Because that's sort of the soundtrack to my life right now.
Yeah. That makes sense. Well, thank you so much for your time, Chelsea. This was awesome.
Thank you.
We learned a lot. And again, thank you so much.
Thank you for having me, Rohan. I really appreciate it.
Thanks for listening to Good Medicine, and a special thank you to Dr. Chelsea Clinton for sharing her perspective. If you're a physician, we'd love for you to join the Roon community at roon.com. That's www.roon.com. You can also help us grow by sharing this podcast with a friend or colleague. Until next time, thanks for being part of the conversation.